So we finished with the nervous system on Tuesday. And today we start on physiology. And just like how we started out talking about the nervous system, this isn't anything new. The stuff I'm going to talk to you guys about this morning, none of it's new. You guys have all been exposed to it. You guys all took an exercise physiology class. You guys all got exposed to the Krebs cycle. You all got exposed to the different energy systems and how all of that progresses. The problem is you were exposed to it from someone that had the perception of an exercise physiologist because they were an exercise physiologist. Exercise physiology is important, but how much of that did you walk away from your exercise phys class thinking, this is going to be something I deal with every single day? Did you walk away with anything from that class that you thought, from a rehab standpoint, I'm going to utilize this every single day? No, because you're taught about the physiological processes associated with exercise. You're not taught about how those exact same processes are the processes that we leverage every day from a rehab standpoint. So all we're going to do today, we're going to talk about some of those same things. We're not going to go through the Krebs cycle and find out where the ATP breaks off and everything else like that happens. We're not going to go into that level because that's not the level that we need to go into it from. What we do need to do, though, is go back to this stuff and re-examine it through the lens of rehab. Because everything we do from a rehab standpoint that doesn't leverage the nervous system leverages physiology. So everything we do from an intervention standpoint, we are either having to leverage changes in the nervous system, neuroplasticity, or physiological changes. It has to be one of those two. Like we talked about before, the nice thing when it comes to leveraging neuroplasticity, leveraging the nervous system, the top-down processes, we can make rather quick changes. From a physiology standpoint, physiology doesn't change. Physiology is the same. You can't cheat physiology. The negative side of physiology is it takes a little bit of time, which is one of the reasons why in our world, atrophy is one of the biggest things that ruins our day, that we propagate and we don't understand the problems that it's creating. And what I mean by that is, if Aaron Rodgers, we all saw that happen on Monday night, or we've seen it by now. He goes down. He ended up tearing his Achilles. He's walking around in a walking boot. Let's say that doesn't happen. Let's say he goes down. It's not an Achilles tear, but they put him in a boot just to be on the safe side. Because how often do we do that? Somebody hurts an ankle, let's just put him in a boot to be safe. We see that all the time. Or let's put him in a sling, let's protect the area, let's rest the area. We see that every day in the world of athletic training, right? Let's take Aaron Rodgers as an example. They put him in a walking boot. The minute they put him in the walking boot, what is guaranteed to happen? Guaranteed to happen. The process is, the moment they put him in the walking boot, the process has already started. Atrophy. Disuse leads to atrophy 100% of the time. The problem with atrophy, the giant problem with atrophy is the one physiological process that violates all the rules I just said. Meaning, if we can't cheat physiology, and physiological adaptation takes a long time. Atrophy is the exception to the rule. You put somebody in a walking boot, in 48 hours, you're starting to see a decrease in cross-sectional area of the muscles that are immobilized. By day 5, it's up to 8%. At 2 weeks, you're talking 25% loss of cross-sectional area of the muscle. Well, what does that have to do with anything? What happens when a muscle gets smaller? It gets weaker. Its ability to produce force is decreased. Okay, well, that's not that big of a deal. You have a little bit weaker muscle, we can make it stronger. You're right, we can. But in 14 days, that 25% decrease in muscle mass that we experience, do you know how long that's going to take to get back? 6 to 8 weeks. So we're putting them in a boot to protect them, but we're causing problems that take weeks to rebound from. Now, in Aaron Rodgers' case, he tore his Achilles. Is he going to be worried about the 25% muscle mass loss he's going to experience in the next 14 days? No, he's not going to be. But how often do we put people in a boot from a protective standpoint just in case something's going on? We'll follow up in 2 weeks. And in 2 weeks we follow up, oh, there's nothing going on, let's get you out of the boot. No big deal. Yes, big deal. We just lost muscle mass. What else happens when we lose muscle mass? What happens to the time? We put me in a boot, my gastroc, my soleus, all of my long toe flexors, all of my long toe extensions, because they're now immobilized and not functioning, they're not being used, they're all going to atrophy. They all get smaller. What else happens because of that? What kind of sensory input have I been getting through that foot for the last 2 weeks? None. So now, remember that whole use it or lose it principle we talked about in the nervous system? Now the sensory input I'm getting, those pathways, they've been turned way down. So the quality of sensory input I'm getting is horrible. I have now muscles that are getting poor sensory input, that have a poor ability to generate an output because now they're weaker than they were before. What's going to happen to the timing of what needs to occur at my knee and my ankle when I start to walk or when I try to do anything sport related? It's going to be thrown off. So now I've created a strength problem under the guise of protection. I've created a neurological problem under the guise of protection. I've created a mobility and a stability problem because if we put somebody in a boot for 2 weeks, things are going to stiffen up. We're going to lose dorsiflexion, big toe extension. I've now created a mobility problem. I've created a stability problem all under the guise of protection. Now, again, Aaron Rodgers, in the world he's living in, he's not worried about any of that stuff right now because he has an Achilles tear. All of those things are going to happen because of what? The actual structural tissue damage. But how often do we see individuals, athletic trainers, clinicians, physicians, err on the side of caution and immobilize to be on the safe side? Because we're not causing any problems. We don't understand the problems that we're creating. And I'll go back to physiology. We don't understand our physiology. So what we're going to talk about today is all the same exercise phys stuff that you guys have been exposed to before, but we're going to come at it through the lens of looking at it day-to-day rehab stuff. You're not going to be tested on the Krebs cycle. You're not going to be tested on what happens to pyruvate and how it does all this other stuff or where lactic acid comes from. Don't worry about that stuff because that's the only time you're going to see it, and I just put that there because I thought it was a pretty neat graphic to put in there. So, okay, so now, oh, that's not the question I want to ask. This is a question, nope, this is a question I want to ask. On your paper, write down all the clinical adaptations that are controlled by physiology. When you're working with your patient, what are the things that you're trying to create that are controlled by physiology? What are the outcomes you're trying to get that are controlled by physiology? All right, so what are you guys writing down? What are some things that some of the adaptations that you encounter every day that are controlled by physiology? I just want to write it down so I don't forget it. What do you guys come up with? What was that?
Muscle length.
So elongating muscles. What else?
Muscular hypertrophy.
What else? There's got to be more than that. Otherwise, we aren't nearly as busy as we try to be. What else you guys have? Okay, decreased swelling. What else?
I put everything with a question mark.
The catch-all. Actually, everything. But here's the thing. Do we understand how the intervention that we're doing is changing physiology? And I don't think we do. And when I say we, I don't just mean we in the room. I mean the universal we as a profession. And I would take that even further. A bigger universal we as a healthcare industry. Because just Monday of this week, I had the conversation about why putting boots on people is a big mistake when we don't know that there's something going on. And do you know why the physicians will, somebody goes out, they go out to our walk-in clinic out at the Ortho Hospital in Ozark, and this is an actual case. Tournament of Champions a couple years ago, maybe this past year, this year or the year before. Tournament of Champions, one of the top 25 basketball recruits in the country. His class comes in, he lands funny, hurts his foot, hurts his ankle, can't finish the game. We're providing coverage, so that happens. We make a phone call that night. We get him seen out at the Ortho Hospital first thing the next morning before the clinic opens so that we can figure out what's going on and they can do what they need to do. They take x-rays, and it's mid-foot pain, it's not an ankle. Mid-foot pain. They take x-rays, they look at the x-rays, no fractures. They send it off to the radiologist looks at it, no fractures, everything's relatively normal. So, you have this high-level basketball player, had a mechanism of injury, no fractures, all the special tests that we're doing, the only thing that's bothering him is when you palpate over that, it's sore. Everything else comes back normal. What do you guys, what do you think the next step was? What was that? Dealing with the pain. What was their mechanism for dealing with the pain? Put him in a boot. So we have this athlete, high-level athlete, no fracture, no concern about a structural issue, and we put him in a boot. And so the question comes up, okay, well, why did you put him in a boot? Well, honestly, it's a COAA thing. We have this person, it's the foot, there could be a fracture and then we're just not able to see it right now. If he comes back in 2 weeks and we re-x-ray that and we see that there's a fracture there, we can get sued because we didn't provide appropriate care. And putting a boot on the kid at this time meets the standard of care. Okay, you're not wrong. It's a horrible reason to do it. And the ironic thing is, we put the kid in the walking boot that day and told him, you need to be in the walking boot. You can't ever come out of the walking boot. The kid scored 25 points that night. And then he scored another 20 points the next night. So we put him in this walking boot on the guise of protection when the kid was fine. Because we think that we need to protect that just in case. Wonderful. But now let's have a conversation about we put him in the boot to protect him from something that might be there that we've missed without understanding what we're causing. Because all those things that we're going to cause we're going to cause. We're going to lose the cross-sectional muscle mass. We're going to lose the strength. We're going to lose the sensory input. We're going to create a mobility problem. We're going to create a stability problem. And guess what happens? Let's say 2 weeks this kid goes by. Let's say he stayed in the boot for 2 weeks. He goes back, he sees the doctor. And this I'm just using the example of our ortho hospital because I get these examples all the day. This could be any primary care physician. This could be any ER you go to anywhere. That's going to be the same standard anywhere. He goes back to his primary care physician 2 weeks later. They re-x-ray that. And there's a legitimate reason to re-x-ray that. 2 weeks later, a fracture could show up because the foot and everything, it might be a little bit of a delayed response on the imaging. That's normal. That happens on a regular basis. We go back 2 weeks later, x-ray comes back, the x-ray is negative. We now have no concern about a fracture. He's not having any pain. What are they going to do? Get out of the boot. You don't have anything going on. Go back and play basketball. And they're going to send that kid back to basketball with a 20+% loss of muscle mass, poor sensory input. They created a mobility problem. They created a stability problem. They created all these problems, and there's no return to play. It's go back and play basketball. That kid sprains his ankle that day. Whose fault is it? The healthcare industries, because we created a problem. We knew that this problem, atrophy is not a new thing. It's been around forever. We knew that we were going to create this problem. We just put our head in the sand because we don't want to acknowledge it. So everything that we do from an intervention standpoint, because we'll play worst case scenario. This kid's in the boot. What can we do clinically, knowing that atrophy is going to happen because he's in the boot? What can we do clinically the day they put him in the boot to offset that? Everything. Because we know the physiological process, and this is why the physiology side of things is so important. We know the physiological processes that are going to happen that lead to atrophy, that lead to the decrease in sensory input, that lead to the mobility problems, that lead to the shortening of the tissue. We know those entire processes. Which means if we know the processes, we know what we can do to stop or slow down those processes. We just don't do it. So anytime we have anybody, post-op is easy. Somebody with swelling, somebody with pain, all of that's easy. But how often in our world do we have somebody that's in a boot, that's in a sling, that's on crutches, that, oh, we can't do anything with you because you're in a boot, you're in a sling, you're on crutches, you're in a brace. The first 2 weeks, the day we immobilize somebody, we have to start doing these things. Because if we don't, if we work really hard in 2 weeks to address all of these negatives that we know that we're creating, we're still going to have some of those negatives. There's still going to be a little bit of a loss of tissue length. There's still going to be a little bit of loss of muscle mass. There's still going to be a little bit of loss of sensory input. But instead of a lot that takes weeks to overcome, we have just a little bit that we can overcome in a very short amount of time. So we work hard in this 2 weeks to offset the physiology that we know is happening, so that when we get here and out of the boot, we aren't looking at a 6-week problem because we just let that stuff run rampant. It's easier to slow down the loss of dorsiflexion in 2 weeks than it is to try and regain a lot of lost dorsiflexion in 6. It's easier to slow down the loss of strength over a period of 2 weeks and loss of muscle mass over a period of 2 weeks than it is to, best case scenario, it's going to be 6 weeks before they get that back. 6 weeks if you do everything right. And then we get into the actual clinical application, and I'll tell you, our application of strength principles isn't going to fix it in strict 6 weeks. We're not getting the volume or the intensity in the rehab world to create those changes that we need. So understanding what's going on from a physiological standpoint allows us to leverage those very specific interventions to slow things down. We're not going to stop this stuff from happening. As good as we are, they're still going to be in that boot for 23 hours of the day. At best case, again, in the college and the high school environment, you're going to have access to that athlete every single day. You can spend time with them every day. That's best case scenario. In an outpatient clinical world, you're going to see that patient for maybe 2-3 hours over the course of the week. It's going to be a little bit tougher for you. But in the collegiate world, you can drastically reduce the loss of muscle mass, the loss of all of that stuff, because you have access every single day to those athletes. We just need to know what to do. That's why it matters, because we need to know what to do. I forgot that slide was in. And yeah, I know I spelled stupid wrong. If I'd have made this on my iPad, it wouldn't have been 2 O's, it would have been 1 O with a little umlaut, a little 2 dots on top of it, but I don't know how to do that on my laptop. All right, why it's important. Almost all of you guys saw this. Did we talk about the OODA loop last year? You guys don't know what the OODA loop is. There is, after we talked about this in class, there's a CEU lecture on the clinical OODA loop. I'll put that link in the course notes. So if you want to go back and watch it, you guys can. We'll talk about it next year, but if you want to get a precursor and know some of the stuff, it'll be there. So when we think about the OODA loop, observe, orient, decide, and act. The observe and the orient, that's our subjective and objective assessment. We're trying to figure out what's going on with this person. We're trying to collect data points and see what's going on. The decide, we're taking their mechanism, we're taking what we found in our subjective and objective, we're figuring out what's going on, we're deciding what the priorities are. And then the act is where we're going to apply our skill set, our hands-on manual skill set, our exercise skill set. We have to understand, oftentimes what ends up happening is we jump straight to the act. We have an ankle sprain. Oh, we're going to do this exercise, this exercise, this exercise. This is why having pre-programmed protocols is a waste of time. Because I'm not treating an ankle sprain. I'm treating the physiological issues that are going on with that person. And I don't know what those are until I see that person. Because the first thing we have to know is what adaptation are we trying to create? And in our world, what ends up happening is we randomly pick an intervention before we pick the adaptation that we're going after. It's an ankle sprain, we're going to do heel raises. Okay, that might not be wrong, but that's just throwing crap up on the wall and hoping it sticks. We need to have a little bit more information. Can you have an ankle sprain where let me ask you this. Ankle sprain. We do ankle specific strength work, right? We can do some banded work, we can do heel raises. Why do we do all of that stuff? What was that? I thought you said something, sorry. Why do we do the TheraBand ankle exercises? Why do we do the heel raises? Why do we do the anterior tip stuff? Why do we do that? That's what we were taught. Why were we taught that we needed to do that? Strength. Not wrong. How many of you guys have done hamstring curls following an ankle injury? Yeah, hamstring shut down more than the gastrocnemius does following an ankle sprain. But we're not taught to go after hamstring, we're taught to do the ankle stuff. Now, I'm not saying that stuff's wrong. There is a very specific time and place to do the 4-way TheraBand ankle exercises. That's a wonderful drill to do, but you're not going to create strength with that. And I'll argue till the other person gives up that they're not. And the reason that you're not, you can't create strength, you can't even create hypertrophy because either the intensity is not high enough because they don't make a band heavy enough, or you're not getting adequate volume. So depending on if we're talking strength or hypertrophy, both are driven by different things. They're good, but they're good to increase blood flow. But we're taught that they increase strength. They're not a strengthening tool. They're good for blood flow. All right, so all the physiological adaptations. The everything really isn't that many things. The everything comes down to this list of 10 things. So when we're talking about the physiological adaptations that we're trying to create with our clinical interventions, somebody's had surgery, somebody's had an injury, somebody's had a trauma. That's what SID stands for. I'm just lazy. surgery, injury, trauma. Somebody's had some kind of injury. These are the 10 things that we're trying to address from a physiological standpoint. And that's it. These are the only 10 things. So that list of everything really isn't that big. There's only 10 things that we need to pick from. Why is this important? Because as soon as I know I have something, somebody comes in with an ankle sprain, I need to see what's going on with that ankle. Objectively, subjectively, I need to run them through, see what the landscape of that ankle sprain actually is. And then my interventions are going to be geared on which of these adaptations I'm trying to create. And again, this is only if we're talking about somebody that's had some kind of injury. This doesn't apply if we're talking about somebody that's, we'll call normal. If we're talking about a healthy or normal individual, we have 9 physiological adaptations that we can create. This is where the emphasis of exercise physiology comes into play, because this is all exercise physiology stuff. The previous one isn't. And I think it's important to look at all of them together. There we go. Because we have to understand the baseline. And the baseline is injury. Is there, those are the blue ones. Is there a structural issue? Do we have compromised structure? If we do, we have to pump the brakes and we have to focus on the tissue adaptations, the physiological adaptations on the previous slide, the ones in red. Because we need to get them back up to a normal baseline. If they don't have an injury, if they haven't had an injury, if they're considered normal, if they're considered healthy, if they're not in pain, then we need to figure out which one of these 9 physiological adaptations that we're going after. Oftentimes we see these as, well, okay, this is just to help somebody perform better. Not necessarily. I have a patient right now, IT band problems. I have an inflamed IT band. Okay, tell me about this inflamed IT band. She's sitting there on the table, an inflamed IT band. So obviously, she's telling me she has an inflamed IT band. The physician's telling her she has an inflamed IT band. Obviously, when she's sitting there on the table and I'm looking at her IT band, it's red. I mean, her whole lateral leg is red, it's swollen, she can't flex her knee, she can't extend her knee, it's tender to the touch. No, it's not. But if it were an inflamed IT band, there would have to be inflammation. How many of you guys have actually seen an IT band that looks like that? Not at all. Most of the time we see an IT band that's an inflamed IT band and it just hurts right here, right? But it's called IT band inflammation or an inflamed, we treat it like an inflammatory response. It's not inflamed. You have to have all 5 signs and symptoms of an inflammatory reaction for it to be an inflammatory reaction. Why is that important? Well, because if it's not an inflammatory reaction, the physiological targets I have are going to be drastically different. So she's sitting there, not an inflamed IT band, and she's talking to me, and she walks in, and everything looks fine. You know, because I'm watching, how does she move? Is she shifting her weight? Is she favoring that side or anything? Couldn't tell anything was going on. So she's sitting there, she's talking to me about this, and I'm asking her when it bothers her. It's pretty simple. I go out for a run and my knee feels fine. I warm up, my knee feels fine. Walking around the job, my knee feels fine. You know, around the house, my knee feels fine. Okay, so when does your IT band get inflamed? I go for a run, I feel fine, but about the 3-mile mark. Usually somewhere right after the 3-mile mark, my IT band flares up. She says that. What starts flashing in my head? Any guesses? Number 4. It's a force production issue. You could probably lobby me to a muscular endurance issue. It's a strength problem. I assess her. Pain with palpation? Oh. Knee range of motion? Full. Even if you look at the magical, mythical tibial rotation, it's wonderful. Hip range of motion? Perfectly good. I do whatever the funny test for the AT band is where they lay off the back of the table. That hurts her knee. But I knew that to begin with. What does that test tell me? Oh, IT band. I knew that when she walked in. So I did the test just so I could say I did the test, but the test told me nothing. Ankle looks fine. What other tests are there that we do for IT band? Does that pretty much summarize everything? Yeah. I could have looked at the ankle. I didn't because I didn't need to. So we have that information. What are we going to do with that? We don't have a physiological target. At this point in time, we don't have a physiological target. Pain is not a physiological target. If you notice, pain's not on this list. But how often do we chase pain in rehab? 90% of what we do is to chase pain and to address pain. Pain's not a physiological adaptation. If you chase pain, you literally are going to be chasing your tail. When we address this, pain becomes a secondary issue. When we address the physiological issues that are going on, pain will take care of itself. Chasing pain won't fix physiology. So, at this point, what are you going to do for this girl? What treatment are you going to do? Because this is the point where, as an athletic trainer, we jump right into our interventions, right? If you don't know physiologically the adaptation that you're trying to go after, you're making the wrong decision 100% of the time. Now, you might be right occasionally. But if we're going to celebrate all the times that we're right when we take a shotgun approach, we can't just sweep those times when we got it wrong underneath the rug and pretend it didn't happen. You might get it right once or twice, but you're going to get it wrong more often than not. All because you skipped a very simple step. You have to know the physiological adaptation that you're going after. Because at this point in time, I don't know what to do for her. I don't have anything physiologically to address. I think that there's a strength issue, but I haven't confirmed it yet. So what do you think I need to do? I need to do a strength test. I put her on the leg press, and we've been leg pressing people at Health Tracks for 20 years. So we have 20 years of data. I can tell you that if we put you on a leg press, you need to, at minimum, you need to be able to single leg press your body weight. If you can't do that, you're going to have problems. If we do a double leg press, it needs to be a minimum of 1.5 times your body weight. So you weigh 100 pounds, you need to at least be able to do 150 pounds. If you can't do that, you're going to have problems. You have a strength issue. Let alone the difference left side to right side, which, depending on what you look at, will be anywhere from 8 to 12%. 12% is kind of the line that we look at based off of our history at Health Tracks. Research says 10%, so 10 to 12%. I put her on a leg press. She weighs about 140 pounds. On her leg that wasn't bothering her, she leg pressed 95 pounds. On her leg that was bothering her, she leg pressed 75 pounds. So before we even have a consideration about what's the difference between 75 and 85 pounds or 95 pounds, what's the first thing that jumps out?
It's too low on both legs.
It's too low on both legs. She's running. She is controlling. Her body weighs 140 pounds. Every time her foot strikes the ground, depending on which article you read and how fast she's going, she's having to decelerate and control anywhere from 2 to 5 times her body weight. Is that more or less than the 95 pounds she can single leg press? Way more. She showed up to a gunfight with a pea shooter. I'm surprised at this point both knees aren't bothering her. Now, but Brandon, a leg press is a lot larger range of motion, a lot slower movement than the quarter of a squat she's going to do in a fraction of a second. You're absolutely right. But if I have a strength issue here, that if I have a force production issue, when it comes to incorporating time into force, which means either power or endurance, power and endurance both involve force production. So if my force production is low, power is going to be bad, muscular endurance is going to be bad. Because force is a component of power and endurance. And if I'm starting out low, endurance is going to be bad, power is going to be bad. So now, and then I go ahead, I test her hamstrings. And we have about a 25% difference in hamstring strength. So we have both legs are weak. The leg that is bothering her is actually weaker than the other leg, but both are bad. What physiological adaptation am I going after with her? Force production and muscular endurance with a little bit of power sprinkled in there. I now have a target. Do I need to do any manual work with her? Is there any manual technique that is going to allow me to improve force production, muscular endurance, or power? There isn't. Can I do some stuff because we know that that's irritated and calm it down? Absolutely. I can do that if it's irritated, but what's more important? She's on my table, her knee's not bothering her. I spend time doing manual work to not get any outcome from it, or here's what you need to do when this becomes irritated. Yeah, so my manual work is education. I'm going to educate her on, okay, you're going for a run, you get to this point. These are the things when your IT band's irritated, these are the things that you need to do at this point in time. Because I can't do anything now because I don't have a physiological target. Where we're going to spend all of our time from a rehab standpoint is working on strength. Because until that goes away, unless she stops running, we're going to get to a point where her force production is the biggest problem. So we now have a physiological target. As soon as I have that, I now have, these are the sets I need to do, these are the reps I need to do, this is the volume, the intensity I need to do it with, and then I need to pick what the appropriate exercise is. But I have to work that way versus just picking a random exercise.
What do ANAE LDS mean?
Oh, anaerobic endurance, so muscular endurance, anaerobic endurance, aerobic endurance, and long duration steady state endurance. So 7, 8, and 9, we're getting into the cardiovascular system, our energy system. Without oxygen, with oxygen, and then well into a state with oxygen. So when we think about somebody that's had some kind of injury, any of our manual work, any of our stretches, mobility, our breath work, the modalities that we use, I don't know what you guys do, but I don't use modalities. I use modalities because I have them do fancy mobility work while they're on E-stim. Modalities. It's a new thing. Google it. You won't find anything. Fancy typo. And then our postural work. Any of the stuff we do in our postures kind of is an area that blurs the line. So when we're doing any of our hands-on stuff, we have the potential of addressing all 10 of these things. We just have, what we end up doing though, instead of making the decision, I want to improve mitochondrial function, we make the decision, I'm going to use Graston, or I'm going to do cupping, or I'm going to do dry needling, or I'm going to do active release, position release, postural restoration. We make the decision to do this fancy thing when we have it backwards. I need to know what adaptation I want so that then I can pick the intervention that I'm going to do. Because then we can actually go after a very specific thing and not just hope that the intervention we're doing works. When we talk about the healthy physiological adaptation, this is where our corrective exercise comes into play. Some of our postural work, Our sport-specific stuff, if I'm doing deadlifts, I'm doing deadlifts to go after one of these adaptations. I can use the deadlift to accomplish several of these tasks, but I need to, and that's why it's important to understand which one of these adaptations I'm going after, because that's going to dictate how I have them do that deadlift. I don't mean how I have them stand over the bar. I mean how much weight I'm putting on the bar, how many sets they're doing, how many reps they're doing, how much rest they're taking in between. Because if I'm going after hypertrophy, hypertrophy is driven by training volume. I need to get a high level of training volume. So I need to have a higher number of sets. I need to have a higher number of reps, which means the weight I have on the bar is going to come down just a little bit. We're going to get a significant amount of volume to trigger hypertrophy. If somebody tells me, and with that, we're going to have about 60 seconds of rest in between each lift. I'm not going to give them enough time to fully recover because I need to create an environment where they have to have an anabolic response. Volume's going to do that. If, though, we're having a conversation about force production, strength. If we're having a conversation about force production, I'm using the deadlift to generate force production, now I need to have a fresh nervous system because force production, I need to leverage the action potentials. I need that nervous system to be engaged. I'm not trying to create local physiological changes. I'm trying to create systemic physiological adaptations. So if we're having a conversation about force production, I'm doing a deadlift. Now instead of doing a high volume, my volume is going to be low. We're going to do sets of 3 to maybe 6 on the upper end. I'm going to do a lot of sets, but my intensity, how much weight I have on the bar, is going to be ridiculously high. And when I say ridiculously high, it's going to be 80% or more of their estimated 1 rep max. So how I load the bar is going to be drastically different just between those two. And those are the two closest on here. If I'm going after muscular endurance, now we're looking at an extended amount of reps. We're looking at 15 to 50 reps, but we're only going to do 1 or 2 sets. But because we're doing so many reps, the volume the weight on the bar has to be a little bit lower. If we're going after anaerobic endurance, how I have them do that, it's going to be, again, you tell me which one of these I'm going after, it's going to tell me how much weight I need to put on the bar, how many sets, how many reps, how much rest to give them. If I don't know any of that stuff, and I'm just doing strength stuff, we fall back to the 3 sets of 10. How often do we do 3 sets of 10? 3 sets of 10 won't increase strength the way that we do it. 3 sets of 10 falls right into the range of hypertrophy. We just don't have enough volume, so it's not going to work. The original 3 sets of 10 is actually a protocol that if we did it today, nobody would come back for the second set. The original 3 sets of 10, how it was originally done, and all the research on 3 sets of 10, because 3 sets of 10 will work and it will create a lot of hypertrophy and will also create a lot of strength. Not the way that we do it though. The way that it was originally done in the late 40s and 50s, it gets a lot of responses, but we won't get people to do the second set because you're working at 1 rep max weight, way higher than what we're doing now. If they're below the baseline, we have to know what we want so that we can pick what interventions to pull that off. Just a real quick note on inflammation. Like I talked about in the AT band, we see this term thrown around a lot. Usually the only time I actually see true inflammation is if there's an infection going on. I've never seen somebody with patellar tendonitis actually have an inflammatory response. Why is that important? Because if I'm going after an inflammatory response, the physiological adaptations I'm chasing and trying to create are drastically different than if it's a non-inflammatory response. And if we call it an itis, and we're having to go after all of this, that's going to drastically change my clinical interventions. The problem is we chase itises and our clinical interventions are based at an inflammatory response and controlling an inflammatory response when there's not an inflammatory response. So our clinical interventions aren't doing anything because that's not the problem. So if we look at these 5 things, Where does the redness come from? The redness comes from increased blood flow and an increased response to inflammatory cytokines. If that's not there, if I don't have an inflammatory response, then I don't need to decrease blood flow to the area. I don't need to pump out the inflammatory cytokines because they're not there. Where does the pain come from? It can come from the structural damage. It can come from the inflammatory cytokines and the pressure from the swelling. Increased temperature is coming from the increased blood flow and the increased metabolic activity. The swelling, increased tissue permeability, increased blood flow, and the loss of function is coming from the actual sensory input of pain from the structural damage, as well as the secondary pain, and then the swelling that's accompanying it. So if somebody has an inflammatory response, these are the things that I'm having to take off the table. If I'm targeting this stuff, but it's not on the table, I'm not creating change. I'm wasting my time. So that's why it's important to understand if we're dealing with an actual inflammatory condition or a misdiagnosed inflammatory condition. And and if it's just semantics, okay, that's fine, let it be semantics. Just understand, if you're looking at somebody that has patellar tendonitis and you don't see these 5 things, it's not an inflammatory response, you shouldn't be targeting this stuff. So if we're gonna call it an itis and leave it at that, fine, we're just gonna call it an itis, don't treat it like an itis. So we can still call it an itis, but understand we're not gonna treat it that way. So that IT band tendonitis that I got the other day, and I call the doctor back and say, hey, you're a freaking idiot. There was no inflammatory response. No. Okay, yeah, you have an inflamed IT band. Whatever, we're gonna do this. And I didn't target any of this stuff. Now, I gave her the tools to where if when she was running, she experienced any of this stuff, here's the things that you need to do on your own. But I didn't waste my time and energy in the clinic addressing this. Can you guys all see that? You guys are young, you have good vision, right? 2015. I'll actually, when I put the notes up for class, I'll actually put this where it's readable. These are the physiological adaptations that were in red when somebody has an injury, a structural issue. These are the clinical interventions that we have access to. Sustained dry needling, pistonine dry needling, exercise, grafted, blood flow restriction, voodoo band, active release, passive release, myofascial release, static stretching, dynamic stretching, foam roller, cross ball, elevation. I'm not going to read them all. You guys can read them. But we look at all of these things that we have access to. Here are the actual physiological adaptations that they create. Why is that important? Well, let's just say randomly, have you guys all seen blood flow restriction? Blood flow restriction is an amazing tool when it's used right. And I'm not even gonna get into when it's used at the right time. How's that? I'll better say it that way. Blood flow restriction is a really amazing tool when it's used at the right time. The problem is it's often used, but not at the right time. So all the amazing benefits of blood flow restriction aren't achieved because what we're trying to get out of it isn't one of the things that it does. So we look at those 10 things, those 10 physiological adaptations. Blood flow restriction, it's going to affect blood flow. Now, we often think, well, it's in the name, it restricts blood flow. It does restrict blood flow. But what's more important, what happens after you take the cuff off? It increases blood flow. So blood flow restriction, the title is a misleader. Long term, it actually increases blood flow because you have a rebound effect. So blood flow restriction increases blood flow after you take the cuff off. Why is that important? Well, if somebody has an inflammatory response, somebody's inflamed, somebody has a swollen knee, is blood flow restriction a good idea? No, because it's going to increase blood flow. And if we have a swollen area, do we want to increase blood flow to that area? Maybe towards the very end, if we're trying to get some good stuff in there, we want to increase blood flow, increase the oxygen, increase the good nutrients. But acutely, that's the opposite of what we want to do. So if we do blood flow restriction, because it's going to decrease blood flow short term, we're actually making the problem worse. We have to understand what the implement gives us before we take the right time to use it. So it does a great job of increasing blood flow. It creates a hormonal response. That ischemic environment that the intermittent occlusion creates, it creates a hormonal response, a systemic hormonal response, like we talked about the other day. It increases sympathetic tone. It increases a fight or flight. Have you guys all done blood flow restriction at some point? Do you like? Is it fun? No. It hurts and you want to take it off, right? That's a sympathetic response. That's a fight or flight response. So all the things associated with the fight or flight response, you elevate everything when you apply blood flow restriction. So if you're trying to calm them down, if you're trying to create a parasympathetic response, and you do blood flow restriction, you're doing the exact opposite. If you have them you bring them in, we're going to do some diaphragmatic breathing. We're going to try and upregulate your parasympathetic system. We're going to try and get rid of some of your anxiety. You spend 15 minutes doing that, and then you do blood flow restriction, you just wasted 15 minutes. Because you just brought them down, and as soon as you put that on, you just ramped them right back up. So in that instance, don't waste your time, just put the VFR cuff on. You're increasing mitochondrial function. You guys remember the mitochondria of the cell, the powerhouse of the cell? It's where all the energy of the cell comes from. This is the only place we're going to talk about the Krebs cycle. This is where the cell creates ATP. ATP is what the cell needs to function. If the cell doesn't have enough fuel sources to function, the cell's not going to function appropriately, which means it's not going to be an asset to what's going on. It's going to be a liability. You have enough cells becoming a liability, you have an area that becomes a problem. So we increase metabolic function, we increase mitochondrial function, we increase the ability of the cell to be a cell and do the things that it's supposed to do. When a bunch of cells start to do that, you start to see the tissue health increase. So we want to go after mitochondrial function anytime there's anything that's going to actually decrease that. What decreases mitochondrial function? Effusion, lack of movement, injury, all of that. Trigger point work. We've all done this, right? Somebody has a trigger point, we dig our thumb in it. Remember, you're digging your thumb into the trigger point, but that's not where the trigger point actually exists. The trigger point exists in the cortex. So blood flow and lymph flow are purple because we can have a secondary effect on those. If we have a trigger point that's occluding blood flow, if we address the trigger point, we take the trigger point away, we can increase blood flow. It's a secondary benefit. If we have a trigger point that is occluding the lymphatic vessels, if we take the trigger point away, we can increase lymphatic flow, but it's a secondary increase. Doing trigger point work doesn't automatically lead to an increase in blood flow. It doesn't automatically lead to an increase in the ability of the lymph to flow. If we take them away, they can have secondary benefits on those. Can help with AP propagation because we're providing a lot of sensory input to the brain. This is where the resolution of trigger points come from. Trigger points are a neurological issue. We're addressing the physical expression of that. But understand, when that trigger point goes away, it has very little to do with what you did here. It's not a local physiology thing. When that trigger point goes away, it's because of what you did within the nervous system. Trigger point work increases the fight or flight response, increases sympathetic tone because that trigger point hurts. I'm now digging into that. We're going to increase fight or flight. It can increase mitochondrial function, and it can also help increase the tissue's tolerance to stress. Dry needling, the pistoning technique. You guys familiar with dry needling? So take a needle, put it in. You can there's a couple different techniques. You can take the needle, you can put it in, and when you move it around and you're repeatedly, I don't want to say puncturing, that's the wrong word, but you're repeatedly moving that needle, that's the pistoning technique. Get an increase in microvasculature, so you're going to get an increase in blood flow. You're increasing sensory input, so you're getting action potential propagation. It's going to create a hormonal response. Just the sheer act of putting a metal needle into the body creates a hormonal response regardless of the technique you use. you're going to get an increase in sympathetic tone, so an increase in fight or flight, and they can also help with the tissue tolerance to stress. It doesn't fix all things. If I want to improve mitochondrial function, there's really nothing out there that shows that the pistoning technique actually does that. If I want to change the collagen makeup, this is one of the reasons, a lot of people will actually needle scars. Well, if you look at the size of the needle, and if you look at the quantity of scar tissue, you're not making any change. You just structurally, you aren't able to make enough change to change the collagen mechanically. If we look at dry needling, where instead of the pistoning technique, they twist it, so then they put the needle in once, they put it into the target tissue, and then you twist the needle and take up the slack. It'd be just like if I have the needle here, I twist, see what's happening to my shirt, it winds up the fascia, it winds up the tissue around it. That's what's happening with the twist technique. You also get an increase in microvasculature, you get action potential propagation, you get a hormonal response, but here we have a difference. You get a parasympathetic response versus a sympathetic response. Here you actually are affecting collagen as well as tissue tolerance to stress. So when I'm dry needling somebody, if I'm dry needling a scar, and I'm trying to manipulate that scar tissue, I'm not going to be using the pistoning technique. I'm going to put the needle in, I'm going to twist it until they feel a deep, dull ache, and I'm going to let that sit because that twist is putting the tension across that collagen, which is going to then change the collagen, or has the potential to change the collagen. So again, knowing the physiological adaptation I'm trying to get changes the technique I'm going to utilize. Let's talk about this one, ice. If you're an athletic trainer, we all have our own specific techniques of making the best ice bag on the planet. All are probably right, all are probably a little wrong. Here's what ice does. It changes tissue temperature and it increases sympathetic tone. But doesn't it also decrease blood flow? We're cooling the temperature. You're right, it does. When you take the ice off, what do you notice? What was that? It warms back up. What color is the skin when you take the bag of ice off if it's been directly applied? It's red. Where's that redness come from? It comes from a release of histamine, it comes from a release of bradykinin, it also comes from an increase in localized blood flow. Because after about the 8-minute mark of ice, you don't get a decrease in blood flow, you get a rebound effect of an increase in blood flow. So ice, if you leave it on more than 8 minutes, is going to increase local blood flow. So this is where understanding the tool becomes important. How many times have we put ice on somebody to reduce inflammation? We want to decrease blood flow to the area. We've all done it, right? We wrap it on, we let them walk out. Now, best case scenario is the thing that we try to prevent. When I was at Oklahoma State, after football practice, they'd come in, we'd wrap ice on them. We knew the ones that as soon as they walked, they came in and got ice because they had to get ice. They didn't want ice, they just had to get ice. We knew who they were. We know the ones that as soon as they got where we couldn't see them, they're going to take the ice bag off and throw it in the trash can. How do we know that? Because the ice bag's in the trash can. So what do? We use even more wrap to make them have to work harder to take it off. They're actually the ones that were getting the most benefit out of the ice because they were taking it off before the 8-minute mark. Those athletes that we were trying to decrease blood flow to, where they wrapped it on and they left it on for the 20 minutes or 30 minutes or until all the ice melted, after the 8-minute mark, they were increasing blood flow. So the athletes that had the potential to actually get the outcome that we wanted were the ones that we were trying to stop from doing the thing that they were doing. So when we use ice, we are going to cool the tissue temperature. There are times where that's important. We are going to increase sympathetic tone because ice creates a fight or flight response. But we also have to understand we are going to increase blood flow with that. There is a period that if you put ice on, you can decrease blood flow, but it's not how we typically apply ice. You have to put the ice on and it's only on for a few minutes and then you take it off. Otherwise, they get a rebound effect and blood flow actually increases. The modifiable strength variables, I have to know which thing I'm going after? I'm trying to prevent atrophy, trying to create force production, hypertrophy, muscular endurance, or energy system changes. Talked about atrophy a little bit before. We severely underestimate the negative effects of atrophy. I can't think of a patient that we've had in a boot for whatever reason where the problems that we were addressing after they came out of the boot were actually the reason that they were put in the boot. All the things that we're trying to address are the secondary effects of them being in the boot. They were put in the boot because they had full dorsiflexion and they had a fracture of the base of the fifth. They need to be protected. I'm not saying that we need to get rid of boots. Patient, somebody has a fracture of the base of the fifth. Is there any reason why a fracture of the base of the fifth metatarsal is going to cause us to lose dorsiflexion? No. We're not talking the ankle joint. We're not talking the ankle capsule. We're talking the base of the fifth. You fracture that, it's not going to have any direct effect on the ankle. Guess what happened though after being in the boot for 6 weeks? What happened to their dorsiflexion? They didn't have any. What happened to their big toe extension? They didn't have it. Is there any reason why fracture of the base of the fifth is going to affect big toe extension? No. We created those by putting them in the boot. We do need to protect, and I'm not saying that if we have issues, we shouldn't put people in the boot. We have to put people in the boot to protect them. There are times when we need to do that, but we also have to understand, when we put them in the boot, we know we're creating problems. Person came out of the boot after 6 weeks. Surprisingly, they had no issues on the lateral side of their foot. We spent the next 6 weeks trying to restore dorsiflexion, trying to restore big toe extension, and trying to get their calf back. We spent 6 weeks addressing the problems that we created by putting them in the boot. Guess what they did in those 6 weeks from the time they were in the boot to the time they came out of the boot? Absolutely nothing. Because what can you guys do from a rehab standpoint when they're in the boot? Well, I can actually, instead of this being a 12-week process, we can cut it down to an 8-week process. Because you send them here when they're in the boot, we get them out of the boot, they need to be out of the boot for 2 weeks and they're back to doing everything. Instead, so in my world, 2 weeks, that's 4 visits. That's $2,000 out of that patient's pocket. It's $500 a time billed to insurance for 2 weeks. We see them for 12 weeks, do the math. It's a lot more expensive than the 8 weeks of once a week for 6 weeks to address and get them going with things to offset what we know is going to come versus sticking our head in the sand and hoping that things go right, because we end up fixing all the things that came about from being immobilized. How often, when you put somebody on crutches, do we have to do gait training to break the pattern of them being on crutches? Almost every single time. We have to understand that when we immobilize somebody to protect the thing that we need to protect, that we're creating problems. We need to address those problems the day we give them the problem. We put somebody in a boot, we need to protect them, rightly so. We need to start doing things to offset the issues that we know are going to come, the physiological adaptations that we know are going to come. Whether it's a boot, whether it's a sling, whether it's crutches, we have to start doing stuff immediately to offset that. Because otherwise, because of physiology, it's a week-long process to fix that on the back end, versus just a little bit up front. Any questions about that stuff? The important thing, when you're doing our soft tissue work, when you're doing your hands-on work, before you pick it, what I want you guys to start working on outside of here, and I can't check your work because that would be awesome if I'm like, okay, I'm shadowing you today, let's go. That's a wrong decision, that's the right decision, great. I might try to do that. No. What I want you guys to start working on, what I want you guys to start implementing, keep doing the things that you're doing. But before you do that intervention, take a second to ask yourself, what physiological adaptation am I wanting to get? And is this the right intervention for that? And if it is, do that intervention. But at the same time, understand that there might be something else that works a little bit better. And this is also this is the cornerstone of why the exercise is the least important. Because if I know the physiological adaptation I'm trying to get, I can pick many different things to pull that off. If I come back here, and I'll post all these after class. If I come back here, and let's say that we have a swollen ankle. We have a swollen ankle. I want to increase central lymph flow. So increase lymph flow. I can do exercise to increase lymph flow. I can elevate to increase lymph flow. I can do manual lymphatic work. I can leverage the muscle pump, joint mobs, deep pressure, PRI, which is the Postural Restoration Institute, some of their exercises increase lymphatic flow. E-stim, if it's done properly, can encourage lymphatic flow through the muscle pump action. I can do meditation, I can do inversion, I can do brachiation, aquatic therapy, and rock tape. Those are all of the clinical options I have to leverage lymphatic flow. If I don't have a way to invert that person, I can't do inversion with it. So that one's off the table. If it's an ankle sprain and it's a severe ankle sprain and it's really swollen, the exercise I can choose to increase the muscle pump, to increase that lymphatic flow, is probably not going to be jogging or the elliptical or the treadmill. But can I pick other exercises? Yes, I can. Once I know that the modalities, the interventions I have access to, then it becomes, okay, what's this person and what's the situation? I would love, my thesis at Oklahoma State was on aquatic therapy. I could tell you anything and everything about aquatic therapy and all the amazing benefits of aquatic therapy and how we should be leveraging that every single day because of the actual physiological things that it does. Great for improving lymphatic flow, central lymphatic flow. Ask me the last time I did aquatic therapy with somebody. It's been 20 years. Why? We don't have a pool. If we did, would I be using that? Absolutely. If I had access to that, absolutely. But I don't have access to it. If I had access to it, I'd be leveraging. So once we know the adaptation that we want, then it becomes a matter of what do I have access to? What's going to be the right choice for this person right now? And go from there. It's one of the reasons why we put rock tape on anybody. If somebody came in 5 years ago, 6 years ago, if you had a swollen leg, when I started here, we would have our post-op ACL patients come in, and they would have all the junk on their knee, and we'd take it off, and we would send them out with an elastic wrap, and we would wrap it from mid-calf up to mid-thigh. And then it changed, we realized we could do it better, and we started wrapping them from the toe all the way up. And then we realized that, man, those elastic wraps are a little on the expensive side. Can we find a cheaper option? And they have compression tubing that you can put on it. So we started buying compression tubing. We would cut it to length, and we would put it on, and every 2 or 3 days we would change it out because it would get nasty and it would start to stretch. The problem with those, the lymphatic system doesn't respond to compression. Too much compression actually closes the lymphatic vessels. So we stopped doing that. That's why now, we had a patient yesterday, post-op ACL patient. He was in his 50s, his wife was about the same age, and we're taking the wrap off his knee, and the wife was getting ready to leave. She's like, hey, I only ask one thing. When you guys are done, will you wrap that leg back up? Because that thing was hard for me to wrap up. I don't think I can do it. So if you're gonna take that off, will you wrap it back up? And our clinician's response was, no, you don't need it after today. We have something else we're gonna do. And she's like, well, I have to tell the doctor because the doctor said we need to leave it wrapped for 48 hours. I'm like, okay, I'll message the doctor right now, but we're not gonna wrap it back up. What do? We put rock tape on. We put rock tape on to leverage the effusion, to drive the effusion into the lymphatic system. Now, we're in a situation where at the hospital we've seen the benefit. We spend more money on rock tape at Mercy than we do anything else. Like when you look at our annual budget, we buy more rock tape. We spend more money on rock tape than any other piece of equipment in our facility every year. Why do we do that? Because it actually has an impact on infusion when you apply it correctly. Now, if I'm in a situation where I don't have access to rock tape, okay, that's one thing that's off my list. I can pick from all these other things as well. So that's why when you know the adaptation that you want, what's the situation that you're in, what's the person in front of you going to benefit from the most, pick those things. If somebody has an adhesive allergy or a latex allergy, do we do rock tape? No. Do we just stop treating them? No. It's just one thing out of several that we know isn't appropriate for this person. So that's why first thing, you have to know the adaptation that you want. Once you know the adaptation that you want, look at all the things you have to choose from, and then pick the one that's the most appropriate for the person standing in front of you right now. If you do that, you will see a drastic change in the results that you're getting, I promise. Because right now, if we're just picking exercises, we're picking an exercise hoping that it gives us the outcome that we want, when we don't even really know what the outcome is. So start thinking about it through the lens of these 10 outcomes that we're trying to get. Which one are you trying to leverage? What intervention is going to give you the best chance of pulling that off? And then we'll come back on Tuesday, talk about how to do this from an exercise standpoint. And that'll be it. Questions or anything?